Hello everyone. I wanted to make a quick video to show you how to code a physician office case. So remember when we're coding from physician office cases, we code ICD-10-CM for our diagnosis and then a CPT procedure for the office visit, whether it was an E&M code or if there was actually a procedure performed, then it would be the CPT procedure. Unlike inpatients, where we're coding for inpatient hospital coding, we would code ICD-10-CM diagnosis and ICD-10 or PCS procedure. Physician office coders do not code ICD-10 PCS for procedures. They code CPT. So when you're coding physician office cases or hospital outpatients, you use CPT procedures. The only coders to use ICD-10 PCS procedure codes are inpatient facility coders, so hospital inpatient coders. Everyone else uses CPT procedures for the procedure code, and then everybody uses ICD-10-CM diagnosis codes because ICD-10-CM is the only diagnosis coding system used in the United States. So with that, we're going to look for diagnosis codes and then CPT procedure codes in this case. So let's look at the documentation. It's in a SOAP format, which most physician office records follow a SOAP format, which is subjective, objective, assessment, and plan. So under subjective, that's what the patient's complaints are, or the patient's words. Objective is the physician's physical findings, what the measurable assessment is of the patient, what the physician can actually look, touch, feel. And then assessment is what the diagnosis is or the conditions. Plan is obviously the treatment and plan to treat whatever the diagnosis was in the assessment. So under the SOAP format, we always start with subjective. So it says, Mark is here today with the chief concern of low back pain. He said that he has not had any recent back injuries, but over 20 years ago, he strained his back lifting a trailer up by the tongue. He also said that over 20 years ago, he had x-rays done as part of an employment situation where he was told that he had lumbar spine arthritis. He said over the last few months that he has had worsening pain in the lumbar spine that radiates across his pelvis. He said it feels like a lot of pressure, like bones are being pushed together. He says that he has intermittent numbness and tingling down both legs, though not at the same time. He denies any bowel or bladder incontinence. He said he called Dr. Grovett's office to see if he could get an appointment, but was told he needed to see his primary care doctor first. He would like a referral to Dr. Grovett. So now the objective, again, are measurable findings. So the vital signs, his weight's 315, temperature's 96.6, blood pressure's 128/68, pulse 80, respiration 16, general. He's a pleasant gentleman resting in no acute distress. Musculoskeletal low back examination shows no pain or muscle spasm with palpation. Negative straight leg raised bilaterally. No obvious motor abnormalities in his lower extremities. So the assessment and plan are linked together. And it says low back pain. I do think that his history, especially of the paraesophagus, is concerning. I have ordered a lumbar spine x-ray and a lumbar spine magnetic resonance imaging, or an MRI, and he would like to have a referral to a neurosurgeon following that test. Diagnosis 2, hypertension currently well controlled. I have given him a requisition to have some tests, including a lipid profile, basic metabolic panel, AST, ALT, and TSH. We will also check a PSA as well. Number 3, follow-up will be initially by phone later this week regarding his lab tests and subsequent referral. So the other documents in this chart are the actual lumbar sacral spine report and the MRI lumbar spine. Now, you'll notice on the MRI, it does go over the findings, and the radiologist has an impression, mild multi-level degenerative changes on the MRI, and as well as the lumbar spine impression, moderate multi-level degenerative changes. The coding guidelines tell us that if our physician does not link us to that documentation with that diagnosis, we cannot code off this diagnosis. Number one, we don't know, is polytiptin part of the physician's practice? Is that radiologist in the same practice as our physician? Or is this an outsource where the patient was sent to a radiologist office somewhere else in town or somewhere else, and then this report's coming back to our physician? So we would query the physician about this being important, but we can't code off this because if we go back to our physician's documentation, there's nothing stated about the results of those, just that he ordered those. So with that, we can't code the diagnosis off those. And number two, we can't actually code the procedures for those. So again, you can only code in a physician office what your physician and staff personally did. We do not know if that radiology, x-ray, lumbar spine, and then the MRI were taken in this physician's office, so the physician office that our physician works at, or if they went to another office to get those done. In real life, if the radiology tests were done in the physician's practice by the physician's staff members, so there's a radiology tech there, then we could code those. So what we're going to code here are what the diagnoses listed in our assessment, and then the E&M code for the actual office visit. So we're going to code the low back pain and the parathia, and then our E&M visit. We know our patient is established. It says under patient status that our patient is an established patient. So open up your ICD-10-CM codebook, and the first thing we're going to do is code the low back pain. So in your index, go to pain, obviously go to P, and then to pain. And then look for low back. You should see the code M54.5. So now we always look it up in the alphabetical index first and then verify in the tabular. So now flip to M54.5 in the tabular. Once we're in the tabular, we look to see if we have to add any additional characters or digits, if there's any includes, excludes notes, which there are not any. So we're going to assign M54.5 for the low back pain. And then let's look up our second code, the paresthesia. So go to P and then down to paresthesia. And in the alphabetical index, you should see the code R20.2. So now we're going to flip to the tabular, to R20.2, and verify that code. So there's nothing special there. There's not any additional characters we need to add. The excludes note that's listed there doesn't apply to our case, so we're going to assign the R20.2. And now let's do our hypertension is the second diagnosis listed there, so we're going to code the hypertension as well. So in your book, go to H to hypertension. And we don't know the type of hypertension. It doesn't really state, so we're just going to do the default, which is the code right next to the main term hypertension, so the I-10. So now flip to I-10 in the tabular, see if there's anything around that code that we need to be aware of. So if you look at those excludes notes, they don't pertain to our documentation, so we will just go ahead and assign the I-10. And now we need to do our E&M code. So get out your CPT book. And we know that this is in a physician office. We know it's an established patient, so we know we're going to be in code range 99211 to 99215 are the office established patients E&M codes. Okay, so our patient had an expanded problem-focused history and exam because he did more than just the low back pain that he came in with. And then our medical decision-making was low. So we're going to assign a 99213. So the codes for this case are the M54.5, is that the R20.2, the I10, and the 99213.